In this lecture, we're going to talk about spinal trauma. So the traditional way that we approach spinal trauma was with a cervical collar and a long spine board, and this came out of a lot of assumption that the improved outcomes with spinal cord injuries we were seeing came from the spinal immobilization that was done largely in the Vietnam War and the improved outcomes. And now that we've started to break that down and look at it individually, there's very little to no evidence to support this practice. And in fact, spinal immobilization is painful and potentially harmful. Cervical collars, by way of example, cause abnormal flexion of the spine and can create or exacerbate injuries. And it can also compromise the airway by holding the head in an unusual position and restricting movement of the tongue and the jaw. There's multiple types of spinal cord injuries, ranging from no spinal injury at all in the setting of neck pain to somebody with a stable spine without neurologic injury. An example of a stable spine injury would be a chip of the plate kind of in the corner of one of the vertebral bodies, or a fracture of one of the pokey processes or the spinous processes on the outside that muscles attached to that really aren't going to cause any compromise to the spinal cord itself. Then we have unstable spine injuries without neurologic injuries. An unstable spine injury is that an injury that could become worse with movement or cause potentially impingement or entrapment of the spinal cord itself. Then we have unstable spine injuries with neurologic injury. Neurologic injury could be a problem with sensation or motor skills, proprioception or coordination. And then a class 5 is somebody who is seriously injured and it's really unclear what their spinal status is. So somebody that maybe fell off a cliff and is unconscious, has a lot of potential injuries, and we're unable to assess whether they have a spinal cord injury or not. So what we want to do is perform a focused spine assessment. And the way that we do this is assess for pain in the middle of their neck, in the middle of their back. We're going to look for what we call focal neurologic deficits. An example of this would be is if in one area or part of the body somebody has different sensation, or they're unable to movement, or they have sharp tingling pain and sensation. We're going to look for altered level of consciousness. We're going to make sure that they're nice and awake and alert and answering our questions appropriately. We want to make sure they're not intoxicated, and we want to make sure that we're not trying to assess them with what we call a distracting injury. So if somebody has such severe pain, and we're talking a pelvic fracture, a femur fracture, that if you were to poke them with a needle in the arm, they wouldn't even notice it, then that's something that we would consider to be a distracting injury. This is not hand or wrist injuries, minor burns, ankle fractures, because what we want to do is make sure that if they have a spine injury, they're going to be able to sense it. So we have a couple options for extricating and positioning patients. What's pictured here is a KED, or a Kendrick's extrication device. This can be very useful for stabilizing the head and the neck and the torso as a unit, and it has lots of excellent handles that you can use for extricating and repositioning a patient then in a litter. In all cases, you want to maintain neutral anatomic alignment and gentle cervical traction. So for spinal immobilization, we should consider immobilizing a spine for somebody that has a potential unstable spinal injury, associated neurologic injury. By that we mean somebody that has a problem with either sensation or movement, potential paralysis, or it doesn't even have to be complete paralysis, but if one part of the body is different than the other in the context of back or neck pain and a significant injury, then we should be worried about the potential for an associated neurologic injury. We're worried about it in patients with severe trauma or suspected injury, but we can't get a really good assessment because they have an altered level of consciousness. So there are multiple things that we can use to mobilize the spine. On the right is the traditional backboard and the cervical collar, and we're starting to move away from this in the out-of-hospital environment, and particularly in the wilderness environment. There are very few instances in which a true backboard is going to have a lot of added benefit. On the left is something called a vacuum mattress, or lovingly called the suck sack, that has a lot of advantages over the spine board. The vacuum mattress is superior in many ways because it has excellent stabilization by conforming around the body. It is much more comfortable than being on a backboard. It has incorporated in it the ability to provide cervical mobilization. It's nice and warm. It has a lot of insulating qualities, and it can decrease injuries. With the backboard, it puts a lot of pressure on the back of the head and the sacrum and on the back of the heels, and also causes this abnormal straightening of the normal curvatures of the spine, and can cause injury that way as well. The way that the vacuum mattress works is it comes with its own pump, and it has a bunch of small beads inside that become rigid when all the air gets sucked out, and it conforms to the body and can work as a standalone full spinal immobilization unit. It molds around the neck and around the body and under the knees, and can prevent cramping and pressure wounds. So we can see here that they're conforming around the neck and underneath the knees while somebody is using the vacuum to suck all the air out. And then you can see in the middle here it becomes fully rigid, and you can move the patient using this vacuum mattress alone. Cervical collars, there's really no evidence that they have significant benefit, but there is evidence that they can cause harm, particularly in altered or unconscious patients. It straightens the normal curvature of the spine and distracts injuries. It can compromise the airway. However, if you do use it to try to mitigate some of these problems, make sure that you're using 2 to 4 centimeters of padding underneath the head to pad the occiput, as well as to provide some natural anatomical alignment for the neck and the airway. In this x-ray here on the right, you can see that the spine has been straightened out with the application of the cervical collar. The C-spine normally has kind of a reversed C-shaped curve to it called the cervical lordosis. And in here you can imagine if they had an unstable spine injury, by the time you put the cervical collar on, you can actually cause inappropriate straightening of the spine and cause the injury to get worse. But the good news is there's other ways that we can accomplish immobilization of the head. We can use the vacuum mattress. You can also use padding on either side of the head. There are many instances in which we can get away from having to use a cervical collar. With a backboard, we should be used with the cervical collar. And the way that we use the backboard is we roll a patient onto it, and we first secure around the chest, and then the hips and the thighs, and then we do the head last. And the reason is if we have to move the patient and we have the head immobilized first, then it can create a significant amount of movement in the head as we turn that patient, and actually cause a significant worsening of their cervical spine injury. So what does this look like in practice? So this is a kind of a decision aid flow diagram on how we can kind of apply these principles. So starting with the blue box here, if we have anybody with penetrating trauma, like a stabbing or a shooting or something like that, it could be penetration with an ice axe or a ski pole, there is very little to no instance in which that's going to cause any kind of meaningful spinal cord injury. So these are not patients that need to be immobilized. In patients with a significant mechanism of blunt trauma to the body, and we're concerned of a spinal injury, then we want to ask several questions. Are they severely injured? Are they unconscious or have an altered level of consciousness? Do they have an obvious abnormality in their neurologic exam? Do they have a significant distracting injury? And if the answer to those questions are yes, then we're probably not going to get an adequate enough assessment, and we should consider immobilizing them. If they have none of those things, then we want to move on to our examination. Do they have significant pain over the middle of their neck or the back along their spine? If the answer is yes, then we should probably consider immobilizing them. If not, then the next question is, are they able to flex their neck and extend and rotate their spine, both their cervical and their thoracolumbar, at least 30 degrees in each plane, regardless of pain? And if the answer to that question is no, they can't rotate their neck or their back despite significant pain, then that's somebody that we should consider immobilizing. If the answer to that question is they can move just fine, then this is not a patient that needs to be immobilized. We are far more likely to cause harm to this patient. This is based on a couple good research articles, the Nexus C-spine criteria and the Canadian C-spine criteria, and you can find references to these online, but these are both excellent, very commonly used decision aids that are used in the emergency department that are very well applied in the wilderness environment. So some of the key principles Consider immobilization for patients with potentially unstable spine injuries, neurologic injuries, or severe trauma. The vacuum mattress is superior to the backboard and a cervical collar. Cervical collars are unproven and have a lot of associated risks with them, so be very cautious when deciding to try to use them. And in all instances, maintain neutral position, adequate padding, and frequent reposition to try to reduce harm.